Hello, everybody. Thank you so much for joining us for today's webinar. Azeo Biologics is proud to host today's webinar as a continuation of our digital education series in an effort to support healthcare professionals during this time. In today's webinar, Dr. Gaitonde will share his experience using the Kangaroo envelope and methods for preserving long-term CIED pocket health. Dr. Gaitonde received his doctorate of osteopathic medicine from University of New England College of Osteopathic Medicine, followed by his residency at Indiana University School of Medicine. He completed his fellowship in cardiovascular disease at Indiana University School of Medicine, followed by a fellowship at St. Vincent Hospital and Healthcare Center in clinical cardiac electrophysiology. He completed 1 year of EP under Dr. John Miller at Indiana University School of Medicine, and an additional year of EP under the teachings of Dr. Eric Brostowski at St. Vincent Hospital and Healthcare Center in Indianapolis. Dr. Gaitonde is currently a member of the University of Louisville Physicians Cardiology Associates and practices out of various locations in the greater Louisville area. He has been in practice for over 12 years. And with that, Dr. Gaitonde, I will turn it over to you.
Well, thank you. Thank you, everyone, for taking some time out of your busy practices to listen to some of the things I'll be talking today, and as well as how I handle my clinical practice. So first, a couple of disclosures, which is obviously the customary thing all speakers have to do. So today's objectives are basically to introduce the Kangaroo envelope, to give everyone out there a meaning of what ECM truly is, to understand a deeper understanding of this new technology and how it will benefit you as well as your patients, and also to give an idea of what patients can most benefit from it. I also want to share some of my clinical practice methodologies just for you out there to get an understanding of why I use this particular envelope, what long-term pocket health means to me, the concept of pocket stability and pocket health, why systemically connected vascularized pocket is important, pocket aesthesis and cosmesis, as well as the concept of pocket pain. So what is ECM, or extracellular matrix? So we'll be going over the components, the function, how it works with the body to regenerate site-specific tissue, and the concept of how ECM regenerates healthy tissue versus creating scar. So first, the components of the ECM. So it has composed of growth factors, structural and fibrous proteins, including collagen, elastin, fibronectin, and laminin, as well as glycosaminoglycans and proteoglycans. The basic gist is to think of this extracellular matrix as a bioscaffolding that makes up all the cells and tissues of our body. So what is the function? Again, ECM, or extracellular matrix, is a naturally occurring bioscaffold that's used in the field of regenerative medicine to restore and repair damaged tissue. When implanted, cells migrate to the ECM, and through a process of remodeling, the ECM will actually turn into healthy tissue, as opposed to scar tissue, and as opposed to an inflammatory response. ECM has been shown to modulate the host immune response to favor this constructive and regenerative remodeling, rather than creating a chronic inflammatory response triggered by synthetic materials. So the big thing and the big concept I want you to understand and take away is that ECM promotes natural regeneration. It has the ability to regenerate healthy tissue as opposed to scar tissue due to its ability to control the polarization of the macrophage. So once a foreign body is introduced into the body's immune system recognizes it as such, a foreign body. This signals the monocytes to transition into an inflammatory M1 macrophage, which creates a fibrotic and chronic inflammatory state and leads to scar tissue formation, which eventually creates a fibrotic capsule. Extracellular matrix is different, however. When ECM is introduced into the body, it modulates the traditional foreign body response by transitioning these monocytes from an M1 pro-inflammatory macrophage to an M2 regenerative macrophage. This macrophage stimulates healing, healthy tissue formation, and neovascularization. So in turn, you're left with healthy tissue as opposed to scar. So again, the foreign body attracts this pro-inflammatory macrophage, which again stimulates fibrosis and chronic inflammation, which then leads to long-term potential for thick fibrotic capsules. However, again, with the ECM, we see regenerative macrophage formation, the M2 macrophage, which leads to stimulating of healthy tissue formation, neovascularization and remodeling, and again, long-term tissue, which is systemically connected and healthy. So what is the ECM made out of? Well, ECM is cis-ECM. It's obtained from the submucosa of the small intestine of pigs. The submucosa is found between the mucosal and muscular layers of the small intestine and provides strength to the intestine and serves as a reservoir for cytokines that support the growth and differentiation of intestinal epithelial cells. The key point to take away is that it's decellularized. What does that mean? By decellularizing this material, once placed into the patient, it's not recognized as a foreign material. Rather, the ECM is recognized as the self, as basically common material, and therefore you don't stimulate this pro-inflammatory response. So the applications are limitless. To date, there are over 3 million clinical uses of extracellular matrix products that are used to treat various ailments all over the body, as seen in this diagram. Every single organ system, from GI to GU to cardiac to skin, all of their different problems and functionalities can be used with ECM products. So ECM, as we can see, is not a new technology. Scientists and physicians have been using this material to rebuild and repair damaged structures in the body for years. It's been in the forefront of regenerative medical research. For example, Dr. Anthony Antela from the Wake Forest Institute for Regenerative Medicine has harnessed the power of ECM to actually build entire bladders to transplant into living patients and using it as scaffolding for replacement of entire body parts, such as ears and noses. So we have multiple examples of ECM being used to grow ears, nose, even a kidney. The result is a structure or organ constructed specifically for that patient with their own cellular material to ensure acceptance by the body. So what is the Kangaroo envelope? So the Kangaroo envelope is constructed of small intestine submucosa extracellular matrix, which is rich in growth factors, structural proteins, as well as collagens. The ECM supports remodeling into vascularized and native healthy tissue for the life of the device implant. So the Kangaroo is an envelope for all sorts of devices, from pacemakers to defibrillators to subcutaneous defibrillators, and it's constructed from the cis-ECM that we've already previously discussed. There are 5 sizes which are currently manufactured, which accommodate all current devices which are used by electrophysiologists and cardiologists. And as noted, there's also one available for larger devices such as SICDs. The Kangaroo envelope has this biological biomaterial which creates and leads to healthy vascularized tissue. So porcine extracellular matrix remodels into systemically connected vascularized tissue as demonstrated preclinically. It resists calcification, and it can also stabilize your device to restrict and mitigate migration and reinforce the strength of the pocket itself. It also, therefore, may be able to ease removal of devices from pockets during exchange, revision, or upgrades. Also, vascularized tissue pockets may enhance patient comfort as well. So why is a systemically connected vascularized pocket important? And why is it important to you and your patients? Well, a more vascularized pocket promotes healing and may reduce scarring. This, in fact, leads to a healthy pocket, which in the long term can protect against infection. It's been noted that scar tissue can seal and can also increase the risk of infection. Also, when you're thinking about the long-term health of the patient, generative changes and upgrades may be easier as you don't need to dissect leads from scar tissue, which is both time-consuming as well as problematic, as it can cause potential loss of integrity of the leads and therefore of the entire system. So cis-ECM modulates its immune response, as we talked about, from an N1 pro-inflammatory macrophage to a pro-healing M2 response associated with healthy tissue development and less inflammation. So when you have this pro-inflammatory response, you have stimulation of fibrosis and chronic inflammation, which leads to a long-term potential for fibrotic capsule scarring and calcification. Versus with the ECM, you have a pro-remodeling response, as seen in this picture on the right, which stimulates systemically connected vascularized healthy tissue formation. So in that particular picture, a yellow micropolymer was injected to show the systemically connected vasculature photo. So this becomes part of the patient and connection of the existing tissue in the body. So the Kangaroo envelope. So here are particular patient types that may benefit from the Kangaroo envelope, which include patients with thin skin, low BMI, smaller patients, young patients, younger patients, I should say, pediatric patients, patients at risk of migration and or erosion. Again, more geriatric, advanced age patients, patients who are older, low BMI, receiving higher energy cans and larger devices, patients receiving a subcutaneous ICD, patients at increased risk for calcification, i.e. patients who have end-stage renal disease or on dialysis. So why do I use the Kangaroo? The simple reason, the patient. The other options for a pouch are limited in that the only noteworthy claim is reduced risk of infection. But that's only one aspect of patient care. There's a gamut of different issues that are involved with implantation of devices in patients. And infection or risk of infection is just one of those issues that we worry about as physicians. So infection risk is there from scarring, from calcification. Those individuals have a prior history. But also, as we talked about, thin patients, low BMI patients, geriatric patients. As you often are seeing now in your practice, and I'm seeing in my practice, I'm operating on a subset of patients which are older and older. Older patients have higher risks for a multitude of different reasons, as well as comorbidities, but also dealing with patients who are smaller frame, low BMI, and implanting defibrillators and high energy devices. The concerns are of migration, of erosion. There's also the concept of Twiddler syndrome. While in fellowship, the Twiddler syndrome was introduced, essentially the patient externally manipulating their device, which leads to lead dislodgement and having to revise the entire system. I was told in training that this is a minority, 1% to 2%, but in clinical practice, it's surprising, and that could be also geographically related, how high of an incidence, up to 15% of patients I'm seeing, manipulating their devices, not necessarily intentionally, but with the endpoint of dislodgement and having to go back for lead revisions. So migration is an issue. These also, patients with twiddlers also sometimes have a history of noncompliance and increased risk of lead dislodgement, again, leading to increased cases of revision. Now, the type of device is also important. With larger devices, and again, smaller, thinner patients, we have increased risk of erosion and migration. And then we have the subset population of those individuals receiving SICDs, which, especially in older and thinner population, poses its own set of problems. And another phenomena that I'm starting to see more in my practice, especially when implanting younger patients, is the concept of pocket pain. Pain at the pocket, pain around the device site. Seeing this more and more, as I said, with individuals who are younger or who are prone to calcification and fibrosis or increased inflammation, and having to deal with this subset of patients, which it's difficult to deal with them from a non-invasive standpoint. So in life, we always want to make what we do more predictable and manageable, and that's the key with patients with devices. We're trying to make it more predictable. We don't want surprises, and we always want to make it more manageable to make it more important that the patient doesn't have long-term complications with whatever we're doing in the present. So again, what are some of the risks involved with the procedure and to the patient? Well, obviously, we always think of the high risk of infection, but there are other factors we need to focus on as well. Erosion of the device, migration of the device. leading to possible revisions. The types of device used have their own characteristics themselves, and again, pocket site pain. So we as physicians have traditionally been only concerned about infection. But again, for me, pocket health is so much more important based on my own patient population. So the rationale for using ECM, or why I use ECM. Again, for too long, pocket health has gone by the wayside, meaning it's never been previously a concern in regards to the long-term well-being of the patient. The only thing we really have been focused on is the short-term issue of pocket infections. We physicians have realized that not only are they increased risk of infection, especially with more high-risk population that we're dealing with, but also migration, pocket pain, erosion, and lead dislodgement. By preventing a chronic inflammatory or fibrotic response and stimulating a regenerative and healing response, you're getting vascularization of the pocket, which supports long-term pocket health. By using extracellular matrix, you're promoting a vascular pocket that is free of scarring and calcification, and which can help with decreasing pocket pain in the short and long term, but also protect from longer term issues such as infection. This is increasingly important as patients are living longer and going to have multiple devices implanted. So it's key to start with a healthy pocket from day one, and it's going to be important in long-term care and management of the patient with an implantable device. Nowadays, implanting a patient with a defibrillator at age 40 or 50, they're going to have multiple generative exchanges in their future. And for those out there who have been, doing generative exchanges, you realize how much scar tissue that has to be broken down and carefully removed to prevent any damage to the leads themselves. But now imagine if from day one you started off with a healthy pocket and you reduced all of this calcification, and instead created a pocket, which is essentially tissue, which comes out in one whole amount, versus having to chip away at calcification. That makes your job as a physician a lot more easier and safer and more predictable. So preventing complications, as we talked about, with the healthy pocket and stability that the Kangaroo envelope provides, it may lead to less movement of the electronic device, which again could reduce the impact of non-compliance of the patient, raising their arm, lifting weights, or twiddler syndrome. And as we know, reopening of the pocket is associated with increased risk of infection, well above that of de novo implantation. When I'm routinely consenting my patients, I usually quote less than 1% a risk of infection with a de novo implantation. So if you look at studies, risks of infection can be up to about 11%. Those numbers are primarily driven by re-exploration of the pocket with generator changes or revisions. So if the less time you have to be in the pocket, the better as far as infection, both short and long term. Also, the notion of increased inflammation leading to scarring and calcification. These are processes known to also increase the risk of pocket infection. And we also know that certain patient subsets, such as those patients with end-stage renal disease on dialysis, are more prone to calcification, and we don't want to further enable this process in this patient. There's nothing worse doing a generator exchange and literally having eggshell calcification throughout the pocket, which makes it a lot more difficult to change out a device in a safe manner. And I had mentioned earlier about SICDs. Well, the SICD patients are a unique population. Normally, nowadays, when patients or at least fellows are taught to implant or doctors are taught to implant, traditionally the DFT has fallen by the wayside. Most physicians nowadays do not do defibrillation testing. I'm probably one of the rare ones who still do DFT testing, especially in our non-ischemic patients, secondary to a lot of times non-ischemics having higher DFT thresholds. But in SICD, we all know that you have to do a DFT to make sure the device is actually working. So in this situation, the key is preventing any sort of barrier of defibrillation, as well as preventing the possibility of erosion. And it's not just preventing barriers of defibrillation at the point of impact and implantation, but also long-term going through the life of the device itself. Now, when you put an ECM envelope around an SICD, the capsule undergoes angiogenesis and oxygen is successfully delivered, serving as electrically conductive medium for DFT threshold, and in fact actually helping to improve thresholds and maintaining thresholds over the life of the device. Calcium and thick fibrosis serve as barriers to successful defibrillation. There's also a high incidence of migration in this population of patients due to the actual nature of the device, a larger device on the lateral wall. Therefore, mitigating migration early on is very important. Stability of the device will also prevent inappropriate function and failure to effectively defibrillate the patient. So, and also, given the dynamic BMI changes in patients from very low to very large, this envelope provides a conducive means to maintain baseline DFTs, which is important, especially with this subset of patients. So again, I like to focus on a patient-centric approach. A substantial percentage of my practice is involved in device exchanges, device upgrades, lead revisions, and lead extractions. As we all know, our patients are getting older. And with older patients, we often have smaller and lower BMI patients. And these are at particularly high risk for erosion, especially with larger devices. Therefore, keeping the pocket intact and healthy from day one and healed is very important. More patients are getting gender exchange, as we already talked about, and also upgrades from single chamber devices to dual chamber devices, from dual chamber high energy to CRTD devices. And therefore, keeping that pocket stable and healthy is important if we want to avoid scarring and calcification each time we go back into the pocket, for obvious reasons of reducing the time and ease of the procedure, but to avoid infection going long term as well. Keeping the pocket stable and healthy is also important as we are having to re-explore the pocket with lead removals and extractions and revisions that we've talked about. So here's just an animal model just to show you about remodeling about, in this case, a pacemaker. So as short as 2 weeks, you're already seeing this neointimal proliferation of this tissue. By 13 weeks, it's becoming more and more vascularized. And by 26 weeks, you have a complete pocket of healthy, systemically connected tissue surrounding the device. What are other advantages of ECM? Well, cosmesis and pocket aesthetics are very important to the patient. Remember, the patient has no idea of the lead position, the functionality of the system. They're not sure how good your thresholds are or if you can capture LV threshold at less than 1 volt. What they're concerned about is how it looks on the outside. So therefore, a smaller incision is therefore desired. And one thing I've actually noticed with using this product for quite a while now is that insertion of the device is easier and now can be done with a smaller incision than traditionally that I've had to worry about. And with one of the competitor pockets, one thing you'll notice is that the pocket pouch itself feels almost like sandpaper. And that's different if anybody's used a Kangaroo pouch. It's more lubricious around it, which facilitates easy placement of the device through a smaller incision. Also, pocket pain is something that we're seeing more, especially with younger patients being implanted. Again, increased inflammation and pain in this subset of patients. So a lot of time with individuals who continue to have pocket pain months and up to a year or so after, you're worried about calcification. And in the past, one of the procedures we'd have to go back into the pocket and actually essentially remove the scar tissue, do capsulectomies to reduce pain. That procedure and process, which is quite tedious and invasive in its on its own because we're going back into the pocket. Now, this is something that can be avoided with a Kangaroo pouch. So again, if you can see by looking at the pictures, an ease of implant may lead to smaller incision length, improved pocket aesthetics and cosmesis, and potentially avoid the notion of pocket pain. So now I would like to switch gears and to have some case presentations. These case presentations are short and succinct, but the point is just to illustrate actual patients that I've taken care of and how the Kangaroo envelope has helped me out. So the first patient we'll talk about is patient DK, a 75-year-old male who presented with a STEMI involving the LAD distribution. He was taken to the cardiac catheterization laboratory and underwent percutaneous intervention of an LAD lesion. At that time, his ejection fraction was 25%. Now, during the hospitalization, he also developed atrial fibrillation and had evidence of sick sinus syndrome necessitating the implantation of a dual-chamber pacemaker. Despite guideline-directed medications and percutaneous intervention, 3 months out with a repeat echocardiogram, he continued to have severe LV dysfunction and therefore required upgrade to an ICD for primary prophylaxis. When going back into the pocket, because this patient was implanted with a Kangaroo envelope, the device was easy to explant and there was no scar tissue in the pocket, making the procedure time significantly shorter than expected. Next patient, patient BH, an 82-year-old female with a long-standing history of ischemic cardiomyopathy with severe LV dysfunction. Very thin, very frail, low BMI. Unfortunately, she's also a vasculopath. She met classical indications for ICD placement based on MATA2 criteria for primary prophylaxis. Unfortunately, at the time of procedure, there was no vascular access obtainable. Her left and right subclavians completely occluded, and even her IJs were completely occluded. So there was no vascular access for implantation of the device. So the options were subcutaneous ICD versus an open surgical approach, which obviously she was way too high risk for. So a year later, she did well for about a year. A year later, she suffered from a fall, and slowly the device area started to swell and slowly began to protrude and erode. Eventually, the generator had to be explanted, and the lead, however, I kept it in place with the notion that I may want to reimplant at a later date. So she was fitted with a life vest, followed up in the office, and later decided she wanted to undergo reimplantation. So she later underwent reimplantation with a kangaroo pouch. She healed well, and a year later, knock on wood, she's not had any recurrent issues with lead erosion. Of course, she also hasn't fallen off a Porsche as of late, but that's good too. Patient LT, 56-year-old female with a history of syncope noted to have sick sinus syndrome. She therefore underwent implantation of the dual-chamber pacemaker with no acute issues. She then presented back to the ER with episodes of hiccups. It was noted on a plain film chest x-ray that her right atrial lead had been pulled back into the RA-SVC junction, and the device itself was actually flipped upside down. She was brought back to the EP laboratory where her right atrial lead was extracted and a new right atrial lead was placed. The entire system was now placed in a kangaroo pouch, and she healed well. And to this day, despite her best intent, has not had any recurrent device or lead migration, thereby saving us a return to the EP laboratory. So just some summary and take-home points. The key, what I've been trying to focus in on, is just not about pocket infection. Pocket infection is exceedingly important, but that's just one piece of the pie. It's about pocket health and stability of the device. Pocket health is important, especially in our ever-growing, ever-aging, and ever-changing population. The Zeo Kangaroo envelope is the first and only device of its kind and may truly improve both the implantation process and the long-term care and well-being of the patient. So when you're thinking about the potential of implantation of any sort of device in your patient, screen them appropriately to see if the Kangaroo envelope may be beneficial for them. Again, patients with thin skin, low BMI, smaller patients, advanced age patients, patients undergoing generator exchanges upgrades, dialysis patients, patients prone to calcification and inflammation, younger patients, patients prone to pocket pain, patients with high risk of device migration, those who have exemplified noncompliance or Twidlow syndrome in the past, patients again at high risk of erosion, and also for that special subset of patients, patients receiving an SICD. Remember, now you have something else in your armamentarium to help you. So I would just like to say thank you for, again, taking the time out of your busy schedule to listen and hopefully get some insights into my practice and insights into helping you with your practice. Thank you again, and anybody have any questions?
Hey, Dr. Gaitonde, thank you so much for your time and for putting that together for us. We did have several questions that came in during your talk, so now we'll go towards those. But the first one was, what first made you start using the Kangaroo?
The first reason I started using kangaroo pouches is actually addressing the notion of erosion. The patients I'm operating on nowadays are advanced age patients where it's routinely 80, 90-year-old. I think the oldest I've implanted is a 103-year-old. And a lot of these patients are teeny tiny, weighing less than my Yorkies. And the biggest thing you worry about is erosion. So once upon a time when I first came out of practice, we had Parsonet pouches available. And I used to use those for patients who had really no skin and no tissue, so worried about erosion in them. But those fell off the wayside and were not really available. So this is similar to why I was using a Parsonet pouch, with the added benefit of being biologically available and accessible, systemically oriented tissue, which becomes part of the patient itself. So it helped with that notion of worrying about lead erosion. And that's what first got me into using this kangaroo envelope. And then, of course, I learned of other uses for the envelope, and therefore the reason for implanting went multifold of why I started using it.
Nice. Okay, so next question is, in your opinion, what percentage of patients actually develop a capsule after having a device implanted?
Honestly, it's probably about 100%. You'll be surprised that even those patients who aren't prone to calcification, you open up a pocket 2 weeks after the fact and you're already seeing capsules forming. So, it's hard to predict which are going to be more prone than others. Now, obviously, those patients who have had a history of chronic inflammatory diseases or issues with calcification because of end-stage renal disease, obviously those are higher risk. But I've found that pretty much everybody that I've done into their pockets have some measure of capsule formation.
I see. And so do you typically perform a capsulectomy, and why?
So when we talked about some of the data that your risk of infection can be as high as 11%, and that's published data, and that's driven primarily not by de novo implants, obviously, but by gender exchanges. And the biggest thing about a gender exchange is dealing with that capsule. And I was always taught that when you have fluid in the body that's static, it's a nidus for infection. And for anybody who's opened up a capsule, it's essentially that scar tissue is like Tupperware. And once you close back the pocket, you have this Tupperware type, pocket with fluid, blood, whatever is going to, stay in that pocket and create a nidus of infection. So when I was taught at IU, we were always taught to break down the capsule and try to remove the capsule at the time of gender exchange, so you have better healing and drainage of fluid from the pocket. So for me, with gender exchanges, I've always tried to do as much of a capsulotomy as possible and debulking of the scar tissue. Now, of course, debulking and debridement can be more challenging with patients who have had 3 or 4 gender exchange and had this buildup of scar tissue and calcium for the last 2-3 decades. So that makes it obviously a little bit more difficult. So I try to remove as much scar tissue as possible.
Okay, that's actually a perfect segue for our next question. So, you mentioned an 11% infection rate, and with most of that being due to the higher risk at time of change out. In your opinion, how would the Kangaroo change that?
Well, if you're not dealing with higher amounts of scar tissue, you're not dealing with a hostile pocket, essentially. Theoretically, that 11% is driven every time you have to go back into the pocket, when you have to deal with scar tissue, when you're not breaking down the scar tissue, so you have static fluid. If you now, instead of having this calcium scar tissue, this, in a sense, as I mentioned, or called the Tupperware, and now you have a biologic capsule, which is basically healthy tissue, which can be removed in one sweep of the hand. Now you're not having to build up of scar tissue, and therefore, theoretically, if that was one of the driving factors, it should markedly decrease the incidence of infection at the time of gender exchange or upgrade.
Right. Okay, thank you. Just a couple more here. So do you have any specific techniques when it comes to implanting a Kangaroo envelope?
So I kind of developed the technique as I've implanted more and more. One thing I told you is that the pocket size has significantly decreased. I told you with the competitor pouch, I'd have to actually make a larger incision because of how abrasive it is to get it into the pocket. However, again, with the Kangaroo, you're creating a lubricious, basically coating of the device, which is enveloping the entire device, which makes placement into the pocket much easier. So one thing I learned that I didn't need to make such a large incision, so I could focus on the aesthetics and cosmesis of the product. Another thing is when you're wrapping the leads, underneath the device and putting the entire system in the pocket, I always tie down my devices to the pocket. And I always put my first throw in the device before I put it in the pocket. So I continue doing that, but the envelope itself has those little holes in them. And what I would do is pinch one hole on either side with my suture and run the suture through it So in a sense, you're doing a purse string of that pouch, and then place that entire pouch into the pocket, and then throw a throw to the pectoralis fascia to securely keep it in place. So now you have this nice unit which is securely in place, which again helps because the lead can't get free and the pocket can't move, and now it's completely covered in this biologic matrix. So it helps mitigate migration. But these are techniques I kind of developed with implantation of this device.
Nice. Okay. Thank you. And then last but not least, what benefits have you valued most while using the Kangaroo?
The benefits. See, that's a kind of a tricky question because you're not sure what your benefits are to some extent. Meaning, that sounds kind of cryptic, but meaning that, the whole purpose of putting these in is to mitigate migration, to mitigate lead dislodgement, to prevent erosion and extrusions of devices, to help with, with change outs. Some of these things you're not seeing, obviously. I'm not seeing maybe that the incidence of extrusion. I'm not seeing the incidence of erosion. I'm seeing maybe less. So it's hard to say exactly numerically what that's factoring into, when you're doing this going forward. And also with the generator exchanges, I'm seeing it with upgrades, that it's easier to do an upgrade when everything is in a nice tissue pocket versus calcified and you're having to carefully remove the calcium and debris and debulk the pocket. So I'm definitely seeing that on upgrades of devices, which we're frequently doing. On generator exchanges, because, new implants, I haven't had to take out the generators for a true generator exchange. But again, I'm assuming that it's helping with, healing too. Because a lot of my thinner population patients, I'm noticing that they were worried about their device, quote, sticking out. Now it's because of the tissue formation, it's not quite sticking out and it's feeling better. They're not having pain and they're not worried about the, quote, lump that they're protruding out of their chest.
Nice. Okay. Well, thank you so much. So, if there are no more questions, we will go ahead and conclude today's webinar. If you have any, follow-up questions after today's talk, please feel free to reach out to your local Azeo representative, or you can always send emails to marketing@azeo.com. Dr. Gaitonde, thank you so much for your time. And everyone, thank you very much for tuning in, and enjoy the rest of your day.